This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
All right, Jason, what's going on, man?
Not too much, my friend. Not too much. We're coming into some nice weather up here in Maine. It's great. And it's always a pleasure to be across the screen with you, talking about a pretty cool topic. I'm excited to get into this for sure.
Yeah, I figured today that we would chat about a paper that sort of creeped across my desk just a couple weeks ago. And, I'll say it's not a paper that I think is going to be fundamentally a practice-changing paper, but it's one that asks an important clinical question in, I think, in a topic that is squarely in the wheelhouse of emergency medicine, and it gives us a great excuse to talk about it. And that's going to be status epilepticus. So I think what we'll do is I'll chat about this paper. We'll kind of break it down. We'll get some key takeaway points. And then what we'll do is we'll talk about status and how to manage it. That sound good?
That sounds perfect. I like this structure because you were kind of a shared expert. You're going to lean on my prior experience, my age, but it's how it happens a lot of times, I feel like, in talking with residents. Incredibly well informed, and I'm just leaning on what I've done in the past. So you be the content expert, and it sounds like we're going to be talking about kind of what I do and how that compares to what's out there in the literature and best practices.
All right, let's dive into that article. This article was published in 2024, so relatively hot off the press here, in the Journal of Epilepsy and Behavior Reports. It was published by Woodward et al., titled Comparison of Induction Agents for Rapid Sequence Intubation in Refractory Status Epilepticus, a Single-Center Retrospective Analysis. Airway management is an important early consideration of status, particularly in those patients with evidence of impaired gas exchange, airway compromise, concern for elevated ICP, or refractory status epilepticus. Classically, refractory status is described as ongoing seizure activity despite the first and second line administration of benzodiazepines and an IV bolus of an anti-seizure medication, like levetiracetam. It is the point at which it is time to pull the trigger on starting a continuous anti-seizure medication, such as midazolam or propofol. And once this drip is started, if they haven't already, the patient will no longer be able to maintain their airway. There is very little evidence or guidance regarding the appropriate induction agent for RSI in the setting of status epilepticus. In theory, benzos, propofol, ketamine have anti-seizure abortive properties, yet etomidate, one of the more commonly used RSI medications, has more conflicting and kind of low quality data on its use and status, especially as intubation is a fundamental step in the treatment of refractory status. In this study, this group wanted to investigate the association of etomidate on seizure cessation in refractory status epilepticus. So what do they do? This was a single-center retrospective cohort study of a prospectively collected database of patients with suspected refractory status. Their patient population were those patients admitted to the neurocritical care unit between 2016 to 2023 for management of refractory status, including convulsive and non-convulsive status epilepticus, and intubated in the hospital as part of their management. Intubations could occur in the ED, the ward, or the ICU. Now, patients were excluded if intubation occurred in the pre-hospital setting, if intubation occurred after a single seizure not meeting refractory status epilepticus criteria, or this seizure was suspected to be due to hypoxic injury, or intubation occurred for an alternate indication. Now, patients were divided into two groups. Those intubated with anti-seizure agents such as benzos, propofol, ketamine, which they termed ASI, and those intubated with etomidate, or EI. There weren't any recommendations regarding intubation agent, and further management of status epilepticus was by institutional protocol after RSI. Data collection was performed by chart review, looking at patient demographics, clinical course, continuous EEG reports by attending epileptologists, and medication administration records. Otherwise here, chart abstraction, which, kind of disappointingly, is minimally described. So primary outcome was detection of clinical or electrographic seizures in the 12 hours following intubation. This was selected to give ample time for EEG connection and monitoring. Their secondary outcomes were time to treatment failure, duration of anti-seizure infusion, time to recovery of command following based on GCS motor score, and ICU length of stay, duration of mechanical ventilation, and peri-intubation complications. Now, I think one of the interesting things of this study was this exploratory subgroup analysis that they did with patients already undergoing continuous EEG monitoring during the time of intubation. So this was done to see if there was an immediate treatment response during induction. What did they find? 697 patients were screened, 148 were ultimately included in the study cohort. The vast majority of patients were excluded due to intubation prior to arrival, either by EMS or at another facility. Now, 90 of these patients were intubated with ASI, the vast majority being propofol. The median dose of ASI agent was 1.19 mg per kg for propofol, 1.4 mg per kg of ketamine, 6 mg of lorazepam, or 10 milligrams of midazolam. 58 were intubated with etomidate for a median dose of 0.29 mg per kg. Baseline characteristics were mostly similar between groups, with no parameters reaching statistical significance. Of note, 44.6% of patients were intubated after receiving both a benzo and an anti-epileptic agent, so met the clinical definition of refractory status, with a non-significant but notable difference between groups. 51.1% of the ASI group received both first and second line agents, while only 34.5% of the etomidate group did. And then I think one other thing to comment on is 85% in both groups received rocuronium as their paralytic. Now, to further comment on this patient cohort, 98% underwent EEG monitoring, with a median time from intubation to monitoring of 4.2 hours. And if you exclude the patients already undergoing EEG, 5.1 hours from the time of intubation to the time that EEG monitoring was initiated. Ultimately, no significant difference in clinical or EEG seizure occurrence in the 12 hours following induction was apparent, 25% versus 29% in these groups. There was no significant difference in the rate of post-intubation seizure between groups. There's also no significant difference on the duration of mechanical ventilation, time to recovery of command following, or duration of continuous anti-seizure medication infusion. That subgroup analysis, which is totally exploratory, 24 patients ended up getting intubated while on continuous EEG monitoring, 6 underwent etomidate induction, 18 underwent anti-seizure induction, majority propofol. 61% of the ASI group actually had cessation of seizures at the time of intubation. 0% of the etomidate group had cessation of seizures at the time of intubation. So the median duration in this group to resolve electrographic status was 31 minutes in the etomidate group versus 0 minutes in the ASI group. So at least when they were hooked up, the big difference is seen in this exploratory subgroup analysis between these two different agents and approaches to induction in this group. Now, in terms of safety outcomes, there is no significant difference in post-intubation hypotension between the etomidate or the ASI groups. I think overall, the study is limited and we have to take these conclusions with a grain of salt and these findings. It was a single-center, retrospective, small sample size. It's not an ED-based study. The chart review here methods are limited, with limited description of how they got about these outcomes. There was no control of status epilepticus management after intubation, and if you think about it, the monitoring period of 12 hours, that leaves a lot of room for confounding, such as anti-seizure medication infusion selection and dosing. There was no controlling for the type of ASI chosen or when selecting between ASI versus etomidate. This study also doesn't effectively comment on the choice of ASI. It doesn't really comment on whether ketamine, benzos, or propofol would be the preferred agent. And I think, interestingly here, the time to seizure monitoring with EEG was about 5.1 hours after induction. And to be honest, that does seem consistent with real life, but it doesn't say much about the seizure cessation based on the choice of induction agent. Can you really comment on the effect of an induction agent if you're measuring seizure activity 5.1 hours after your RSI is performed? And actually, 85% of patients received rocuronium, as mentioned earlier. And this could ultimately mask clinical seizure activity that would be more informative of efficacy of these medications. How can you tell if your etomidate or your propofol or ketamine was able to stop a seizure if the patient's paralyzed, especially if you're not getting EEG on board for 5.1 hours? So I think to conclude here, this is a retrospective study that investigates the association of etomidate on seizure cessation and refractory status when compared to anti-epileptic medications for RSI. Although this study did not find a significant difference in seizure cessation when comparing ASI and etomidate for rapid sequence intubation, their exploratory analysis maybe suggests that ASI could be beneficial in status epilepticus termination. We're really just going to need further study at this point given the limitations of this study. This article discusses and evaluates the choice of RSI agents for status, but we don't intubate everyone who comes in for status, obviously. And there are multiple steps that we take before we reach that part of our resuscitation. So I think as a primer, before we get into the nitty-gritty about intubation, I guess, Jason, what's your approach to the patient with status? What should our initial considerations be for this patient?
Great lead-in question. And my collective opinion about status epilepticus is more is better, in my humble opinion. I think it's fair to sort of extrapolate some of the data we see, particularly in pediatrics. It shows that when we make mistakes, when we err, we tend to underdose or space out dosing too far apart. We just don't go as heavy-handed as we should. So for me, it's kind of the American Epilepsy Society guidelines that I generally follow. And I like to keep that framework in my mind. And then if you have, a peripheral brain and Evernote or something like that, can certainly keep their guidelines on hand with you. And we'll have those in the show notes, of course, as well. The biggest challenge I find is you start to put on this hat, right? You put on this status epilepticus hat. But when you first meet a seizing patient, if it's a new seizure in the waiting room, or EMS had a seizure on the way in or something like that, they just started seizing, you don't know that you're dealing with status at the start. So in the beginning, when we're dealing with just the freshly started seizing patient, certainly you're going to get a point of care glucose rapidly. You're going to try for IV access right away, and lorazepam 2 milligrams. In my experience, that seems to really abort most seizures. But as we mentioned, you start to go down this rabbit hole, and you have to be prepared for non-cessation, like not stopping if the seizure is ongoing. So when I ask for that first dose, I will also ask for 4 milligrams of lorazepam at the same time. And that 4 milligram dose matches the REX for kind of max dosing by some of the guidelines. We're going to probably dive into that a little bit, but it matches with that sort of dosing algorithm. Recognizably, the 2 milligram dose might be a little bit kind of under what is recommended when you're really looking at things from a status epilepticus standpoint. So now for timeline, the guidelines say every 3 to 5 minutes, sort of 3, some say 5. In terms of dosing out your benzodiazepine. I think there's usually more operational limitations here that usually make this a moot point. You're moving really as fast as your nurses can move. If you have a status box with meds ready, then sure, you could probably keep it to that 3 to 5 minutes, but otherwise it's often as quickly as you can get your benzodiazepines and dose them out. If you don't have an IV and you have an actively seizing patient after attempt or maybe 2 dual on either side of the arm, for me it's then IM midazolam. The guidelines here I feel like are kind of on the higher side at 10 milligrams IM or 0.2 mg per kg. So depending on the patient size, I might go with a 5 milligram dose, kind of akin to that 2 milligram lorazepam sort of lower dose. But again, we're talking about a plan for rapid escalation. By the time you get to round 2, hopefully we have an IV or an IO. And by that time, when we hopefully have our access, we're giving our round 2 benzos, and we certainly should be giving our anti-epileptic drugs.
You're absolutely right. I think the pathway is clear when you hit 5 minutes or the patient is brought in by EMS and they're actively seizing. You put on that this is status, you put that hat on, and you follow an algorithm. It's a bit more challenging to finesse those that start seizing in the emergency department, right? Because honestly, from what the data shows, most clinical and electrographic seizures end before the 5-minute mark. And in many cases, they'll stop, and you don't necessarily have to pursue this pathway. But those that do extend beyond 5 minutes are much less likely to stop spontaneously. So I think what I've heard and read is there's an argument to be made that treatment of acute convulsive seizures less than 5 minutes, it's just supportive care. You're protecting the airway, you're assisting breathing, you're applying O2, you're doing what you really can to support them through that seizure and not necessarily reaching for benzos, since most do stop. I hear what you're saying about this 2 milligrams of lorazepam. You really have no idea if this patient is going to be one of those patients who stops before 5 minutes or they're well on their way to this being status. I guess do you call your first dose benzo like as soon as they start seizing and give it at the 5-minute mark if the seizure doesn't stop spontaneously? Like, what are you doing in that case? Are you preparing to wait, or are you jumping right in with your benzo if, let's say, they start seizing in the emergency department?
Yeah, great question. And again, it kind of gets back to that logistic versus guidelines, right? So if somebody seizes in the middle of triage, or they seize unexpectedly while they're in the department, and you don't have an IV, you don't have all the meds ready, I think logistically, it's again kind of a moot point, because by the time you have, if you have an IV, by the time you get your seizure box, you get your medications, you're pushing 3 to 5 minutes realistically, unless it's already at bedside, which it generally isn't going to be if you're not expecting this seizure patient. So I am staying at bedside. I'm repositioning the patient, applying supplemental oxygen if they need it, trying to make sure airway is clear, while nurses are essentially scrambling to try to get that benzodiazepine. And usually it is at that 3 to 5 minute mark that you're giving that first dose. Now, let's just make a hypothetical where you have a syringe full of Ativan, of lorazepam, right at bedside, and someone just happens to start seizing.
You don't have that like next to every single bed in the emergency department.
Well, we atomize it in the waiting room, so it makes everyone's experience a lot better. We generally, it takes a little while, but hypothetically, we have it there. A nurse is holding a syringe of lorazepam, 2 to 5 milligrams, and someone starts seizing. I do not think it is unreasonable to reposition the patient, suction airway if needed, make sure the airway remains patent, give supplemental O2, and give it a few minutes, non-specifically, I'd say that sort of 3 to 5 range, to see if this spontaneously aborts. Now, incredibly importantly here is team dynamic, right? If your nurses are aware of this sort of, most of seizures are self-terminating or self-limited, and that you're not going to actively push a benzo immediately beforehand, then you can maintain that sort of relationship. You maintain confidence from your nurses in what you're doing. But if you're just doing this willy-nilly and everyone's kind of used to, there is a seizure, I have to fix it with a benzodiazepine, and you're telling your nurses to hold it, that might be deleterious to your sort of leadership role as a resuscitationist. So I think team preparation is super important there.
Makes a lot of sense. And I'm just going to assume that, a patient who, is seizing, or maybe is brought in by EMS, who sees in this postictal, who then like starts seizing again, like your calculation is going to change in that situation, right?
Yes, totally. And we have to be aware of that sort of definitions. And I think we'll talk a little bit about like what defines true status. But if somebody seizes, stops, remains profoundly postictal, and 5 minutes later is seizing again, then you're down that algorithm, right? So the recurrent seizure, the lack of return to baseline between, you have to count that as status. And as I said, we're going real quick in terms of our algorithm and going down that algorithm.
So there are, like, I think 2 big guidelines that are out there when it comes to status and the algorithms that exist. And they are, I mean, for me as like a resident, seem like relatively old, right? There's the neurocritical care guidelines for status epilepticus that were published in 2012 by the NCC. And then slightly more recently, the American Epilepsy Society published guidelines in 2016. From what I can tell, I think that society is working on an update right now, but they do differ a little bit in sort of their approach to status. And I think it's helpful to sort of like read through that. So the NCC guidelines define status very much how we think about it, right? It's that 5 minutes or more of continuous clinical or electrographic seizure activity or recurrent seizure activity without returning to baseline. But the AES guidelines, they still sort of comment on status as a seizure lasting greater than 30 minutes, but they really have an aggressive strategy in terms of the timeline, in terms of how you're approaching your medications. And the NCC frames the meds as emergent, right? Your benzos, you have your urgent meds, what we kind of think about as like Keppra or like phenytoin, and then your refractory medications. And then AES uses first, second, and third line meds. So there's different ways, I think, to frame it, emergent, urgent, refractory versus first, second, third. There's nuances here. I know I'm pretty biased. I kind of like the framing of the NCC guidelines, right? Knowing that this is an emergent med, this is maybe one that's urgent, and then we now are into the refractory part of your status algorithm. What do you think?
Yeah, no, I totally agree in sort of that leaning toward the NCC. The idea of a seizure lasting greater than 30 minutes, that to me is not a viable definition from an emergency department perspective. right? I'm not going to sit and wait. So, well, it's not status yet because they're at 25 minutes of active seizing, right? It just doesn't hold a litmus test for me. I maintain that sort of same general thought that the NCC does. So I keep with that definition. But interestingly, I kind of tend to lean toward the AES guidelines that we've kind of noted already. And I think we hinted about it before, but just to say it out loud, the sooner you recognize the patient is in status, the better they will do, as long as you're aggressive. So at 30 minutes, you're way behind the 8 ball, in my opinion. And yes, we need to be conscious, right, of that reality that most seizures are short-lived. They're going to self-terminate, as we mentioned. But that's why I kind of approach that first 5 minutes with a little bit of a lighter touch, right? Not that full dosing of lorazepam. Give them a little time, see if they self-terminate. That might be a little bit low dosing or underdosing when you already recognize that someone is in status or you have that status epilepticus hat on. So give them and or kind of the meds time to work. But if they don't work, you are very rapidly escalating.
That whole like time is brain mantra works not just for stroke, but it works for seizure too, right? From like what I know, I think there's a lot of studies out there, or at least experts sort of point towards like 30 minutes, you're definitely having permanent brain damage from like ongoing seizure activity. So definitely super important to act and get that seizure under control.
Yeah, the longer they're in status, the harder it is to get them out of status, right? We generally know that.
You kind of mentioned underdosing and overdosing. So, I think that's a common pitfall that we hear about in the emergency department. So I guess, what are your thoughts on choosing your dosage for status? Like some guidelines recommend that 4 milligrams of Ativan with a repeat dose if it doesn't work. There's some that are like 0.1 mg per kg up to 8 milligrams as an initial load. Like, what's your thought on like how aggressive that medication regimen would be to make sure you're not quote unquote underdosing your benzo?
Yeah, and this is a interesting and challenging question, right? Because if they don't terminate and 45 minutes later you're on your propofol drip, then yeah, my approach probably is seen as underdosing, but that is the vast minority of patients. So again, for me, it's generally that initial dose of 2 milligrams lorazepam, kind of in that 3 to 5 minute time frame, as long as logistics allow for it. I'm giving that a try. I'm letting time see and have its own sort of diagnostic value, but I'm upon calling for that first dose, I'm letting my team know that at the start that the next dose will be 4 milligrams. So I'm moving quickly in dose escalation, and so that's an important thing to just rapidly move down the funnel in terms of care of status. And certainly, yeah, patient's prior history, the prior seizure history for them is at play. So if they have a prior history of status, I might go with that 4 milligram dose to start. Even, if they're a large person, just by sort of Gestalt definition of a large person, I might also give them that 4 milligram start and repeat at 4. I have not started with an 8 milligram dose, and I do have reservations related to dosing that way, kind of having, deleterious effects on the patient who's kind of the easy out, who self-terminates or terminates, with your first dose of benzodiazepine, and how that might sort of protract their somnolence, how it might protract their ED length of stay, those types of things.
I agree. I think that over sedation for a patient that may quickly return to baseline could delay disposition. And it's not a benign thing, right? Both for that patient and for your ED workflow. But I think, the danger here is we shouldn't extrapolate that to respiratory depression. So the evidence that does exist, it does not support the concept that benzos for status promote respiratory depression and intubation. And I really want to highlight that important takeaway for our listeners here. Adequate doses of benzos actually may reduce the need for intubation, because as the seizure progresses, right, it's harder to break. And that's because all of like those GABA receptors on your neurons, they get internalized within your cells. So the longer the seizure goes, the more these receptors are internalized and the less sensitive these neurons are to benzos. So if you're upfront and adequately dosing your benzodiazepines, like really, this is your best chance for immediately lysing your seizure. But yeah, it's a management tightrope. Like, how do you balance adequately loading, aggressively treating, and not putting your patient into a benzo slumber for the next hour or two when they could have been awake and alert and out the door in that time period?
Oh yeah, it's an incredibly hard tightrope to walk sometimes. And You are definitely wise beyond your years, Dr. War, in terms of that pathophysiology and the internalization of GABA receptors. It's an important thing to remember. And thank you for bringing such great sort of pathophys and science behind that sort of thought process to that general idea that the longer someone's in status, the harder it is to break the status. And that's something you could remember as a listener as to why. Internalization of those GABA receptors. So while avoiding additional benzos sort of past that 5-minute mark in an actively seizing patient because you quote unquote don't want to commit them to a tube, it's definitely false logic. And as you mentioned, it's very likely that the opposite is true. Treat rapidly and aggressively for sure.
Awesome. Let's talk about second line or, by the NCC guidelines, those urgent medications. Let's talk about levetiracetam, right? And that's, or Keppra. I'm probably going to trade name the crap out of it today. But this is becoming the favorite second line agent after benzos. I know there's plenty of evidence for valproic acid and phosphonatoin, but I guess, is there a reason you would choose one or the other two medications at this point? Or are you Keppra all the way?
Yeah, so levetiracetam, pick your pronunciation, but
it's too hard, man.
Yeah, right. No, I will default to levetiracetam unless they're already on another agent. If we can do a chart biopsy real quick, and I see that they are on phosphanatoin, then I will use the agent that they are on, or unfortunately, more realistically, sometimes that they're supposed to be on.
2019, there was a bunch of trials that came out. There was ESSET and Eclipse and Concept. There is that equal efficacy between all three, so I don't think we should dissuade the listeners here from using a different medication. But I do think when you have equal efficacy, you do have to kind of think about a superior safety profile. And Keppra is super easy to use. It has a really wide therapeutic window. And ultimately, why complicate things? For me, at least, it's the same effects, but fewer adverse effects and things that I have to think about.
For sure. Same great taste, less filling.
I think that's kind of a point to emphasize here in these guidelines, just for listeners here. So they recommend using these agents after benzos in all patients who meet status criteria. I think some people are we gave benzos and they've broken, but I think you can look at these meds in two different ways. Way one is that they don't break. In 5 minutes, you've given your benzos, and now you're using this anti-epileptic medication to break their seizure, or at least try to. Or maybe you were lucky and that benzo that you gave broke their status. Now, you're now using that medication to rapidly reach therapeutic levels of an anti-epileptic medication. Once you are in that pathway, don't hesitate to give them that second med, regardless of the outcome of their seizure, whether they stop or not. It's important to give.
Completely agree. That's probably a common pitfall in the self-terminating seizure, to not move forward with the anti-epileptic drug, because by definition, they are subtherapeutic in some capacity, right, related to whatever agent they're on. So we need to not only abort the seizure, but we're thinking about, later today, tomorrow, the following days. So getting those anti-epileptics on board is really important and should not be forgotten.
Sounds like we are using, the guideline of our choice, but ultimately we are thinking about rapid escalation of care, recognizing that patient who meets status criteria, and using your team to appropriately and quickly make decisions regarding which medications to give, how quickly to give them, and I think all of the operational things that come in play when it comes to identifying those in status. How do you think about it as a summary there so far before we dive into innovation?
Oh, totally agree. I think just to sort of highlight that other point, or that we talked a bit about, the idea of giving that first seizure opportunity to self-terminate or terminate with dosing of benzodiazepines. I don't think you are wrong to sort of quickly get them on board if you want to give it that sort of 3 to 5 minute time frame to see if there's self-termination, and then administer your first dose, repeat dosing again at about 5 minutes. And for me, my personal preference is lorazepam, 2 milligrams and 4 milligrams. And if you're still behind the 8 ball there, still actively seizing, you can certainly further dose escalate, but recognize that most of these patients aren't going to go on to status. And that early or first round 5 minutes are, sort of seeing how things play out, but then you're right on the gas pedal if they do not terminate.
We've been talking about sort of that initial approach to status, the recognition. We've been talking about which meds to use for your first and second line agents. Now, when do you start thinking about intubation in a patient with status? That's what the article was about. It was thinking about intubation with RSI, thinking about intubation and status. So what about you? When do you go, I think it's time that we need to intubate this person?
Yeah, when do you cross that line in the sand, right? So for me, I'm trying my best to save intubation for the patient who hasn't terminated after 2 rounds of benzodiazepines. And again, as we mentioned, that includes that concurrent anti-epileptic drug administration. So if we're at that point, I'm talking about or thinking about intubation and preparing for it. Now, for the patient that terminates, I'm willing to push the envelope a little bit in that sort of, quote unquote, airway protection realm that we see in some of these cases. Patient has, poor mental state. There's a concern for maybe a mildly compromised airway protection element. That's not really to reason in my mind to intubate the post-ictal patient, because they often can have a relatively rapid improvement in mental state or mental status. Now, if the respiratory drive is really compromised, then you are more likely to be moving toward or need a tube, in my opinion, as you can't really pull out positive pressure ventilation in someone whose suppressed mental state and respiratory drive is down. So supporting them there is tough. If it's oxygenation, you can probably supplement that with nasal cannula, high flow, or other things. But the ventilation is really pretty hard to assist the patient through. So if their respiratory drive is down, then they don't have that sort of internal drive to ventilate after the seizure stops, then I'm getting ready with my tube.
No, that makes a lot of sense here. And right, I think the guidelines do agree, right, on the definition of refractory status. And that's what you mentioned here, right? And that's you've given an adequate dose of your benzo and you followed it up with one of the anti-epileptic medications. It seems like in our case, that's Keppra. So we've given our benzo, we've given our Keppra, they're still seizing. That is refractory status. That's what we talk about sort of in this paper that we talked about earlier. And that's when everyone sort of points towards intubation. We have all of these indicators from like an airway perspective, but ultimately they're still seizing. They've gotten those first and second line meds. It's really time to, I think, switch over to it's time to kind of take that airway. There isn't really a well-defined period of observation after giving that second agent before you can decide this is it, we have to intubate. You really have to weigh the benefit of early seizure control versus the risks of intubating a patient that may have avoided intubation, right? And which is more important and which, can you manage more effectively?
Mm-hmm.
Very complicated, right?
Yeah, challenging.
You've decided we want to intubate and you decide to proceed with intubation. What's your approach? For your induction agent, are you reaching for propofol, ketamine, or Versed, one of the anti-epileptic medications that we discussed in this study, in this journal article above? Or are you using the comparator in this trial, etomidate?
Yeah, this is a super interesting time for me because it's not a typical way to think about this disease process, but it's time in my mind to sort of think about the patient dynamics. And I really think that that's what matters most. And, what I mean here in that area is their vital signs and specifically their blood pressure, actually. So if they're, markedly hypertensive, which many of these patients will be, then I'm going to reach for propofol and sort of appreciate, in this article, that practice affirming data signal that it's a really good anti-epileptic drug. Now, if the pressure is soft or they're hypotensive, then I reach for ketamine. So I'm making a branch point decision between propofol and ketamine.
No, I think I tend to agree with you there. I think although this study didn't really find any significant differences between the two, they did have that exploratory analysis that when people were hooked up on the continuous EEG monitoring and they gave one of these meds, those seizures stopped almost instantaneously compared to etomidate. So even though the outcomes maybe weren't different, this exploratory non-powered subgroup, we can harness it for our own well wishes here, right? Because it does make sense from like a physiologic perspective to give an anti-epileptic medication as your induction agent.
Agreed. Totally. I think there's merit in seeing that, when we have EEG running and we push ketamine or propofol, we see a termination of seizure. When we push etomidate, we don't. Now that's, again, not powered, but it's still important things to recognize physiologically.
I do love etomidate though. Unfortunately, like in this in this case, we're just gonna have to stick with propofol or ketamine here. All right, so we can get into this. Like everyone loves the paralytic talks here in RSI. Succinylcholine, short-acting agent, lets us observe for clinical seizure activity, but comes at the risk of hyperkalemia. Rocuronium doesn't carry the theoretical risk of hyperkalemia, but could hide further seizure activity. I guess, how should the clinician weigh these options in the approach to the actively seizing patient? And I guess, like, what do you think about a no paralytic approach to these patients? Pick your poison. What are you going with here for your intubation and your paralytic?
Yeah, so let's just start with that no paralytic approach. That's not been my practice strategy. And, there are certainly times when we need to approach things from a non-paralyzed patient standpoint. Ludwig's angina, angioedema, if you need someone awake for the process, that makes sense to me. In these cases, success is paramount, right? I think to have to redose or add a paralytic later because the person is too tight is going to lead to bad outcomes. So I don't personally do a non-paralytic approach in these patients. So the sucks versus rock, that war wages on. But in that area, I'm a rocuronium guy through and through for sure, with a handful of important exceptions. And I think of intracranial hemorrhage and seizure as the two most often ones that I consider succinylcholine in. And I think seizure is probably the one where I will dose sucks instead of rock. I want my neuro exam back as soon as possible in these patients. And so unless they have known renal failure or another reason to really fear their potassium, I'm going with sucks. You can, of course, with rocuronium, you can give rock, especially if you're worried about a prolonged tube or a difficult tube to obtain, and then reverse them after. But my general practice is succinylcholine.
Yeah, I am definitely a rocuronium fan myself. I use it for almost all the innovations in the department if I really can. And I really am torn on this specific indication here. And I think I do tend to agree that like succinylcholine may be the move here. And, I will say based on multiple studies that, at least if the patient has normal renal function, succinylcholine really only leads to a serum potassium increase of about 0.5 milliequivalents. I guess, the concern here is rhabdo, right? Rhabdo leading to hyperkalemia. And from what we know about rhabdomyolysis, it takes time to develop. So honestly, status, if you're less than 15, 20 minutes, like itself, probably not going to lead to a level of potassium that with succinylcholine is going to trigger some hyperkalemic arrest that we're all scared of when it comes to succinylcholine and seizure. And I think therefore, like for most patients, that neuro exam is going to be really important. I mean, as someone who's been seizing for an unknown period of time coming in, I don't know, maybe rocuronium is safer in this context. But yeah, I would agree. If you end up going with rock in that patient, we really should think about reversing them if that's something you can do.
Yeah, totally. I, maybe agree to disagree a little bit, and that sucks for the most part. I'm not very afraid of hyperkalemia in these patients. Yeah, if they have had a seizure for an unknown duration of time, or they've had a prolonged downtime and the rhabdomyolysis risk is higher, rocuronium with reversal is fine, but for the most part, sucks all the way.
Hate to hear it. So the patient's intubated. We've gone down this whole pathway. We finally have this person hopefully intubated and teed up. What do you do now? I guess like just briefly round out our discussion and kind of like close us up here. Like what are our key management priorities and workup besides getting this patient out of our ER to the neuro ICU as fast as we can?
Yeah, right. Dispo and upstairs quickly. Now, if you have the ability to do bedside EEG in your department, kudos to you. That's fantastic. Many departments won't have that, but that should not be ignored, or it should certainly be highlighted in these patients, especially, if it's rocuronium or if you're sedating them and you're not sure about their current, if they are actively seizing or not. That is a huge problem for the patient's morbidity and mortality. So getting them to a place where that type of monitoring can be done should not be delayed in any capacity. And recognizably, there's a tendency for us to sort of high five and pat each other on the back and just sort of walk away from any of the tubes that we do in the emergency department. But pretty much like every other patient that we intubate, we need to really avoid that urge. We need to stay by the bedside and make sure that we're caring for the patient appropriately. They need to have a sedation drip. And in my mind, there's nothing other than propofol for this role. If the AED is not already running, you've probably done something wrong, or the patient presented in extremis and you needed to intubate them right away, but the antiepileptic should be started as soon as possible as well. Now, electrolytes obviously can't be ignored, and you're going to fix the abnormalities you see, but if you've gone through this process and you haven't checked a point of care glucose, that needs to be done. And unless you have a really good reason not to, maybe a 20-something-year-old person who was sitting in a comfy chair and wasn't on their anti-epileptic drugs and had a fully atraumatic seizure and came in, most of these patients, in my mind, is going to get that non-con head CT in my department before heading upstairs.
I agree. I think that patient who you can 100% chalk up to did not take my anti-epileptic medication as prescribed. Sure, I think the workup maybe can be, attenuated somewhat in the emergency department. But that intubated status patient, you really have to sort of have that wide net, thinking about all the different causes, thinking about, is this a CNS infection? Is this hyponatremia, hypocalcemia? If they're really young, is this like an inborn error of metabolism? Thinking about stroke or trauma or drugs or drug withdrawal, hypoxia, autoimmune stuff. There's so many different things in the differential for status. And I think there's definitely time to think about that after they're tubed. And I think just being cognizant of maybe some intervenable etiologies before they go upstairs will definitely go a long way towards helping your neurocritical care colleagues for sure.
Completely. I agree. And thank you for sort of doing that bit of a differential, because there is probably a supposition of noncompliance, which probably leads to under recognition of serious illness in these patients. So consider your differential, work your way through it. But as you're doing so, make sure that we're prepping for their ride upstairs, because the sooner they're up where they need to be, the better they'll do as well.
And I think just for those people out there, maybe preparing for boards in the next couple months, just thinking about one, eclampsia, not missing that peripartum or pregnant patient who's coming in, who's actively seizing. That's our opportunity to give magnesium, which we don't talk about at all in sort of our status epilepticus algorithm here. And then, is this person on some TB medication? And we're thinking about pyridoxine, right? That's like your refractory seizure in this setting. So I think just kind of adding some of those zebras in there too. So I would argue that eclampsia is one that we should always be thinking about. I think just thinking about the differential and making sure that you are very deliberate in your management, I think is going to be really important for these patients.
Totally. And just to add to that, hopefully, at 20 plus weeks, you're seeing something on the belly. But if you have a young female and body habitus is preventing it, your bedside ultrasound on the abdomen is hugely important, and it will keep you from ignoring a patient who has a different medication line that we've already talked about today.
Beautiful. All right, Jason. So let's go through some take-home points here. So what do you have for our listeners here? How would you, summarize our chat here? What can they take to the bank after this session?
Yeah, so a lot to go over with the patient in status epilepticus. The first is, again, recognition that giving the patient or first round of drugs some time and giving them the opportunity to declare themselves as a self-terminating or a quickly terminating patient is important. But at the exact same time, in the same breath, when you're ordering your first benzodiazepine, whether or not you wait those 3 to 5 to see if there's self-termination, you're letting your colleagues know that this is preparation for a 5-alarm fire, that the further they get down the status pathway, the harder they are to terminate. And so for me, again, that's lorazepam 2 milligrams as the first dose, 4 milligrams as the second, with the anti-epileptic drug being given at the same time as the second round of benzos. In the patient that doesn't terminate, patient that's fitting that definition of status, which can include that really prolonged postictal state, or particularly if they go in to have another seizure, then we're talking about airway procurement. And for me, it's a conversation about blood pressure, interestingly. So if they're hypertensive, propofol is my preferred, and that's my gold drip for afterward as well. If they're hypotensive, ketamine seems to be a good option as well. And, etamidate's still out there as an agent. There wasn't any major differences in terms of safety for that, but my preferred agents are propofol or ketamine. In terms of paralyzing the patient, I prefer and go for succinylcholine, even though every other case I pretty much will use rocuronium, because I want to try to get my neuro exam back quickly. Once we have the patient intubated, we have to consider that differential, including metabolic with multiple electrolyte conditions, trauma, drugs and their withdrawal, hypoxia, infectious processes, and then again in the pregnant patient, thinking about eclampsia. Trying to get the person upstairs as quickly as you can, safely, without premature closure, just saying, attributing it to noncompliance, so that they can get their continuous EEG monitoring and making sure that they are indeed out of status after intubation is the goal.
Sweet. Thank you for that beautiful wrap up there, Jason. And as always, it's a pleasure to have a chance to talk on SimKit and kind of talk through some really cool things. And this is definitely one of them. We see this all the time, and it's something definitely we need to be prepared for in the emergency department.
For sure. Fun conversation. Thank you.
Thank you for joining our conversation today about status epilepticus and particularly how to manage the airway. Remember that SimKit wants you to be confident and competent, particularly in procedural skills. We have simulation models that deliver right to your door to practice in your department or at home in cricothyrotomy, lateral canthotomy, gastroesophageal balloon tamponade, and tube thoracostomy. Check out the link at the bottom for more.